Freezing, frozen, thawed. Welcome to Canada. Today we're talking about frozen shoulder. I'm Dr. Brad Wiening.
I'm Dr. Paul Zalzal.
We have a guest today.
Hallo, ich heiße Markus Bischoff.
Dr. Markus Bischoff.
Shout out to our German fans. We have something special for you. The whole video is going to be in German.
Sehr geehrte Damen und Gäste, meine Damen und Herren, sehr geehrte Gäste, es freut mich sehr, hier zu sein mit meinen Freunden, Kollegen bei Gespräch mit den Docs.
But he came just from north of where we practice. He's from Ontario. He's of German background. So we're just messing around. Today we're talking about frozen shoulder. It's so awesome that we've been friends forever. Finally, after like 9 years of this channel, we dragged you down here to do some videos with us. Very excited.
I'm happy to be here. Thanks for having me, guys.
Okay. Tell us about frozen
shoulder.
The thing about frozen shoulder, though, I always thought is kind of a cop-out of a name, right? I know frozen shoulder was defined in 1934 by Dr. Codman, and I thought, you know what? It's kind of a lame name for something, because the patient presents and says, hey, doc, my shoulder's frozen. What's going on?
Yeah.
You have frozen shoulder, right? Like it's like saying, hey, doc, I got back pain. What do I have? You have sore back. It's the name. It's like it's when the diagnosis matches the symptom that worries me, right?
First of all, you know what I have to say? It has nothing to do with being cold.
Okay.
These people do not come in saying my shoulder is colder than the other side.
I had frozen butt skiing last year when we got stuck on the chairlift, I'll tell you that much.
Okay, so the other name is adhesive capsulitis. This, you may have heard of this. So it talks more anatomically about the pathology. So let's talk about what it is.
Sure. You know what? I'll start by saying, talk a little bit about the anatomy of the shoulder. The shoulder is a ball and socket joint.
Yep.
It's a very shallow socket and a large ball, like a golf ball on a golf tee. The way the body holds that ball onto that socket is with a tissue called a capsule, which is like a elastic pouch that sucks that ball right onto that socket.
Okay.
This capsule is stretching. It allows for mobility, which is really important in the shoulder.
Most mobile joint in the body.
Most mobile joint in the body, absolutely. Also the most unstable joint in the body, but that's another.
It's another video.
That's another video. This capsule has elastin in it, which is a tissue that allows for movement and stretchiness. Okay. Sometimes this capsule can become very rigid and stiff. This is why it's called adhesive capsulitis. This capsule can become very, very, very hard, almost like leather. So rather than being an elastic band, it's more like leather. Okay. It's a condition that's relatively poorly understood. We don't know why some people get it and why others don't. We do know that diabetics, people with thyroid disorder, cardiovascular disease, and Parkinson's are more prone to it.
So those are the risk factors.
Those are certainly the risk factors. The other big risk factors is immobility.
Okay.
So individuals, let's say, that have had a fracture or break around their arm, let's say, and they're immobilized for a period of time, they are more likely to develop stiffness or tightness in this capsule. Okay. Similarly, with individuals who've had shoulder surgery for whatever reason, if they're immobilized for a period of time afterwards, they are at risk of developing an adhesive capsulitis or frozen shoulder.
Okay.
And this is usually people that are middle-aged or older, more commonly in women than men.
Exactly. It usually presents in 30s, 40s, 50s, rarely in teenagers or young adults, and very rare, to be honest with you, in older individuals as well.
And most commonly not traumatic.
Most commonly not
traumatic. Like someone just comes in and says, doc, my shoulders just got more stiff and more sore. So really, let's talk about
so what's the presentation?
Yeah, what do they show up with?
Pretend you didn't have trauma, you didn't break your shoulder, you didn't have it immobilized. You're just living your life.
Living your life.
Watching Netflix, and then all of a sudden, what happens?
It generally happens, we call it insidiously, meaning without any precipitating event. Okay. Although I have to be honest, most patients say, yeah, I was reaching up to change a light bulb, that's when it started. But in all honesty, I think it's most of the time, it just starts for no reason whatsoever. And it's a very slowly progressive condition. People develop, and you talked about the freezing, frozen, thawing stage. So the initial phase, the freezing stage, is a stage where it becomes progressively stiffer and stiffer, and it's also associated with a tremendous amount of pain.
Right.
So patients present with progressive pain and a less and less ability to move and use that upper extremity.
Right. Okay, and then that leads to, obviously, you're not using it, so then it gets more stiff, more sore, even pain at rest and at night. It's very debilitating.
It's very debilitating. You're absolutely right. Most patients have a difficult time laying on that side. At night, pain seems to be amplified, and they're most symptomatic.
And is this happening over the course of hours, days, weeks, or months?
This is a very, very slowly progressive condition over months and months. So let's say the initial phase can last anywhere from 2 to 12 months, let's say, but usually a couple months, they end up being symptomatic enough that they go to a physician to have this checked out.
All right. So how is it checked out by a physician?
So the first thing is physical examination.
Right.
So this can move the shoulder, and there is an inherent restriction in motion.
Okay.
Now we have to separate that a little bit. In some individuals, if they have pain, they're unwilling or reluctant to move the shoulder.
Right.
This is slightly different. They do have pain, there's no doubt about that, but they have an inherent stability or stiffness in that arm. Even if they were anesthetized, you could not move that shoulder around.
So it really is a stiff shoulder.
It's a tremendously stiff shoulder.
That you're controlling, just uncontrollably stiff. Okay.
That's correct. And then the next phase, the frozen phase, is where gradually over months the pain does subside, but the shoulder will remain stiff.
Okay.
And then the last stage, the thawing phase, is where the motion comes back and pain subsides even more.
And that whole process takes typically
It can take anywhere from 12 to 18 months, sometimes even 24 months. It's a
Okay.
very, very slow condition.
All right. Along the way, is there anything you can do about it?
The hallmark to treatment is movement.
Okay.
Now, it's like we mentioned, it's very painful to move.
Right.
So we often use anti-inflammatory medications, Advil, Aleve, Motrin, those sort of medications to try to settle down the inflammation, which is internal swelling, and also for pain relief.
Okay.
And then movement is absolutely important, so we send people to physiotherapy to aid in trying to stretch and trying to regain the mobility, and also encourage individuals to start moving the shoulder on their own as much as possible.
Any role for injections, for corticosteroid injections?
There definitely is. There's two types of injections, really. A corticosteroid injection, which we often do into the shoulder space, right above the rotator cuff, to help with the inflammation that's associated with it. And also another type of injection is hydrodilation, which is a high volume saline and often cortisone injection as well, right into the glenohumeral joint, into the ball and socket joint, to help distend the capsule a little bit, with the idea to try to break down the stiffness and tightness in that capsule.
And that's usually done in the setting of like an outpatient clinic.
We usually do it in the office. You need to know your anatomy. You need to be comfortable with injections, but yeah, we do a lot of it in the office.
Right. Any role for manipulation? So we have other joints of our body as orthopedic surgeons that sometimes we take to the operating room, put you to sleep, and we say, okay, well, you're not going to move it. Well, I'm going to move it for you. Is there a role for that in this setting?
There is. Generally speaking, this is a condition that does improve on its own.
Right.
But like we said, it takes a long time. So a lot of patients understandably get very frustrated with this absolute long timeline. So what we can do to try to speed up the recovery process is we can take an individual to the operating room.
Yep.
We put them under anesthetic, so we put them to sleep, and then we really just force and move that shoulder. And the idea is to then dramatically, or by movement, break down the thickness of that capsule and regain and allow them to regain their motion.
Of course, risk of fracture of a bone is when you do something like that, but people who've done these on a regular basis are careful and know when to push and how hard to push to manipulate. Don't try this on your own.
But I think one of the take-home messages is, though, that even though you're sore and it hurts a lot, it is safe for you to move it, and you have to do it. There's kind of no getting around that.
It's counterintuitive, because patients often, they come in and say, it's so painful, I can't move it. You say, no, you have to push through it. But it's like, I can't, it's painful. And I understand that. It is a very painful condition, especially in the initial and the freezing phase.
Yeah.
But it is really important to keep pushing. It'll speed up that timeline for sure.
And that's why Dr. Codman in 1934 said it's difficult to define, difficult to treat, and difficult to explain. But you did a great job explaining it.
Oh, thanks.
Take that, Dr. Codman.
There you go. Any explanation why people seem to get it on one side? Obviously, you could get it on a second side, but you don't always get it on both sides, which to me didn't make a lot of sense.
Yeah, it's true.
And I think that's the thing. We don't get it.
No, I think you're right. And this condition, like we said, is still poorly understood. We don't understand why the individuals get it. The one thing to say is that it usually represents as just one side and not the other side.
Yeah.
And once you've had it on one side, it's actually very rare to get it again on that same side.
Oh, really?
Yeah.
There's good news for you.
Takes
Hey,
off.
if you've had frozen shoulder or know someone who has, leave a comment. Tell us how they dealt with it and what treatment option worked for them. That'll help the other people watching for sure.
Right. Great summary. And I think the take-home is know that this is not a totally uncommon thing. Like, I think I saw the incidence in the 2 to 7% range. So people get this. You're not alone. It's going to take a long time, but most likely is going to get better. So take some solace in that and just do the work that your surgeon has assigned you to do, particularly with physiotherapy. And if you like this video, please like it, subscribe to our channel, share it with someone that you know that's got a frozen shoulder.
And if you have a frozen shoulder, you can still hit like, you can still hit subscribe, okay?
Use your other
That's
arm.
no excuse. No excuse.
There you go.
It's good for you. It's good for you. Movement is good for you.
You are in charge of your own health. Thank you, Dr. Bischoff, for
Thanks for having me, guys.
distilling that very difficult to explain topic.
That's
Thanks,
awesome.
guys.
We'll see you next
Auf
time.
Wiedersehen. Tschüss.